The lower limb, the biggest issue with it is either hip or knee pain. Then you got to discern if it's coming from the feet up or not. So the firing patterns and the movement, trying to get some alignment on the pelvis are probably key especially for knee pain. So, I've seen a lot of different things on knee pain. Has anybody had any, what did Smart do? Oh, so they didn't do knees, did they?
Who?
The Dawn Lewis,
No,
when you'd know
it was
that.
rib cage and
Yeah.
I think she probably does, but I only took one.
She does,
Yeah.
but that would be positional release, your muscle energy techniques. But the knee, most of the time, if there's a knee problem, it's a firing pattern problem, which is going to cause a tracking problem. So that's why if we can teach you these things, that then also if you got a tracking problem with the patella, that's what's going to set you up for tendonitis. So with the knee here, so right here, that's your orientation. Up here, you've got, coming into the patella, you've got vastus medialis, rectus femoris, intermedialis underneath, and vastus lateralis. There is a groove that patella has got to move in, and it comes in at an angle. It doesn't come straight up. There's an angle in there. Can you see that? See? I told her she'd be back. Do you see how that comes up at an angle? Can you see it, or do you need to feel it? You see it? Okay. In order for that patella to ride in that groove, it's going to want to go this way. It's got to be pulled over. So that is the vastus medialis that does that. Because of ongoing IT band issues, which it isn't the IT band, it is what's pulling on the IT band. So it will be gluteus maximus, gluteus medius, hamstring, quadricep. That you bring the tone down on those, you'll loosen up the IT band.
Tensor fasciae, their glutes.
Yeah. So, you don't need to dig on an IT band. You're not going to get anything but suffering out of that. You got to loosen up the tissues around it. And because we have a tendency to over-pronate sometimes with feet, there's a mechanical advantage for the patella to be pulled over and the vastus lateralis becoming overly toned. And then that inhibits the medialis. And now, every time the knee bends, there's rub, as opposed to it being over in the appropriate tracking area. Anytime you've got rub, I don't care if it's over a bursa or a bony landmark or whatever, you're going to get friction, you're going to get localized inflammation. So the balance between these two muscles and the firing pattern so that this patella tracks over and then it can slide nicely in its groove will solve almost all of your knee problems. If a person actually has cartilaginous problems, or they've got, the synovial, the hyaline cartilage here is wearing away, you got problems with meniscus, you got problems with the internal ligaments, internal and posterior, anterior and posterior cruciate. Yeah, very good, Luke.
You just take a step up. You keep going.
No, you go ahead.
But you see, ideally, nice and smooth. Beautiful hyaline cartilage on the patella. as well. So that's rubbing or offset and causing a disruption that's going to wear out. And so here, just some bumps beginning to occur. And then here, so this is having a medial issue, which is causing, down to the meniscus and all that, but that'd be a medial knee, and then now we'd have an MCL and medial knee, but even the patella here, right? That cartilage can wear down as well. Yeah.
Beautiful. All right, so the technology on knee replacement is good, and they're getting even better with it. They're resurfacing as opposed to, taking the whole knee out. There's all kinds of good stuff happening. When it's inside the joint, you can put artificial synovial fluid in there. There's different brands that they can go in and they can cause a separation because the fluid in here, there's fluid in here that also keeps that knee apart. So I will say to somebody, they'll say, oh, my knee is swelling. And I will go, oh, a knee that swells is still working. Because there's an increase in the synovial fluid production, but it's trying to keep these bone ends apart. What were you going to do? You're holding on to that.
Oh, just here for the anatomy. It should make sense. The muscle that's closest to a jointed structure is going to be more about stability. So vastus medialis, look how the thicker part of it is nearer to the knee and thus also the patella than the rest of these. So when we get to palpating this, that's an important thing to visualize, that this is more inferior and these are more superior in terms of where the muscle belly and bulk are located. And anybody that has had an individual, or if you yourself have gone through any kind of knee-related rehab and physical therapy and strength training processes, this is what they're targeting. They'll have them doing band work, going into extension and all that. And usually with any kind of knee rehab, doesn't matter what it is, but particularly post a replacement or post an ACL, and that doesn't matter. There'll be a big part of the PT related rehab approach that's about facilitating the strengthening of vastus medialis. That's where you can sound incredibly intelligent and be helpful in that clinical space by being able to understand why that's important, and where we can be really helpful because they are not usually paying attention to decreasing the tone of the stuff that is now over strong. They're going to be focusing on just isolating and strengthening this. So we can have a double effect of helping turn these down while amplifying this. And when we do that concurrent with a rehab approach, that's where the magic can happen. Somebody gets knee replacement, they're seeing you and getting physical therapy. This is where we can make a really big difference, is when we can facilitate this kind of better. Now this is a localized kind of firing pattern sequence, but it's not too much different than the analogy of thinking about the bigger neurologic pairings of things too. Everything ideally should fire together in appropriate order so that movement and everything is as effort-free and damage-free as possible, right?
The other thing we have to consider when we're looking
Damage-free.
The other thing we have to consider when we're looking at the hip, knee, ankle complex is something called closed chain and open chain movement. So when my foot is on the floor, I'm closing the chain. That means that my ankle, knee, and hip function as a unit. When I have the foot off of the ground and it's not closed, it's not hit, this is open chain. Now I can move my ankle, move my knee, move my hip independently. So sometimes people, you do your assessments in open chain, and people will say, well, that doesn't hurt or whatever, but as soon as they stand up, now you're starting to see that there's reduced mobility in the ankle, or the knee is funky, or there's something with the hip. Now all the symptoms show up. So closed chain activity, when we do all these firing patterns, we're trying to address some of that closed chain relationship. But there are a series of exercises that are closed chain exercises, and one of the big ones is a squat. And then standing on one foot and then the other. And again, if somebody is really needing rehabilitation on that, then better off to refer and work with somebody than trying to do that. Because it's real nuanced when you're working with closed chain activity. But walking and the balance that goes with it, that is a closed chain exercise. So with my weird knee, this is an open chain exercise. And I'm trying to get the vastus medialis to fire by giving it some mechanical advantage and turn it in, and I might even put some weight on that leg to try to do that. But I have to also balance with the opposite movement with it, and that happens if you're doing something through a full range. You're going to get agonist antagonist balance with it. A closed chain would be so the ankles and the knee and the hip all have to work together. So a closed chain activity like this would be important if you're getting up and down out of a chair or something. And then you could add a weight, you can put a ball on it, or this is something that I have to work at. And I just noticed when I did that my legs came in, which is telling me my balance is off a little bit. I should be able to do that and not have some of this going on. So that would be an indication of doing the firing pattern where you push together, or the gait thing where you have them push together, strong, pull apart. That would be when you see that in an assessment. Now the other some people want to do on this is they want to get up on their toes because they don't have enough ankle mobility. Ankle mobility ankles are rough. Go ahead, Luke, I saw you.
Well, I mean, it's just speaking to that idea. It's where if somebody has a dysfunction in any of this, then you need to work on all of it. It's as simple as that. And if something's wrong with the toes, it's going to affect the midfoot. It's going to affect the ankle. Up you go. Something's up the knee, down you go, up you go. I mean, it's too closely connected. And this interface ultimately into the pelvis and the low back are where this closed chain domino effect is always more profound. You'll have a little bit less of that in the arms to the neck and shoulders outside of like some postural things with the scapulas and stuff. But here, I pretty much have always been able to make, a good argument to a client that regardless if the symptom was low back, down, how important it was to be sure I was thorough and us looking at, maybe it's just this side, but we also have to make sure that the other leg that's doing well keeps doing well and all of that. But none of these elements, and we don't necessarily always have time to go through every piece, but it's like why incorporate in a session, incorporating toe movements, thinking about the foot and how there's this doesn't do as good a job as this other model, but
Make sure
where
the camera sees
yeah,
you.
I see it, where the tarsals and metatarsals connect. that lateral element from calcaneus to cuboid to the 4th and 5th metatarsals, like that's more structural. This has a lot more bones, more mobile. That's where the arch is. Why keeping that freed up as well as all these other ones are important. A lot of that's done, it's not hard in sideline. That's why a lot of this kind of stuff working on the top of the foot as well as the bottom of the foot is so essential. And just by, now you can in prone and supine maybe manipulate this orientation and make that better, but it's hard to beat the inside line. As I just do massage, that's going to naturally affect the structures in a particular orientation. That top leg, it's going to push them in the opposite orientation, and that's going to take you most of the way you need to. But secondary to that, now we're to the ankle. We talked about the exercise of incorporating dorsiflexion and plantar flexion, but we're just paying attention to getting this action to occur at some point while we're doing massage. I have one where I'll kind of hold on here, I rest their toes. This is the top leg and sideline. So they'll be like this. I'll do that while I'm massaging here. And a lot of that will just happen on its own, or I hold with a hand and do some small, it's just doing minor pulls and pushes incorporated with this just to get this little bit of extra effect, including down here. If I'm doing all the work here, I can just be allowing some effect into the foot cause these little joint movements in the ankle, because as she's saying, that's going to be hugely essential, particularly when we're talking about being able to do these big gross movements like getting up out of a chair, let alone getting truly down into a deep squat. So if you can't do that, if you don't have good dorsiflexion, then that means not only is this going to have more stress in it, it's going to translate up here real bad. And for example, in basketball, one of the things that would usually predispose them to knee-related tendonitis was post-ankle injuries. They would start having to get a lot of ankle taping and bracing, limiting the mobility here and protecting that joint. But then where's that stress going? So post the ankle injury, now they're getting taped and braced, then they start getting knee tendonitis, or patellar tendonitis. It's patellar tendonitis, which kind of gets weird because technically it's a tendon up here and a ligament down here. But patellar tendonitis, and that's how so that gives you a pretty clear connection. But then all of that up to the hip and the pelvis, and then down as somebody's pelvis is all weird. And that's changing how the knee's oriented.
Hyperextension of the knee, I can't even do it, but it causes a ton of hip problems.
So what does the hip have to do to accommodate that? So look at the femur. So if that's going to allow for, now this is really exaggerated, but if a person's walking around like an ostrich, okay, this is really exaggerated. But now, what is this ball?
Do you want to see it in?
You're hypermobile in your knees,
and it's exaggerated.
Well, sure, yeah. But what does the pelvis then have to do?
It has
and
to.
this closed chain orientation has to do an anterior tilt. Then what does that do to the SI joint? It pinches it.
It's better to see this way, I think. And you can see my height.
Let me see.
Make here in the calendar. There you go.
Here, I'm normal.
Ow! Wonderful.
Yeah.
Look at that terrible situation.
Let's do that again. Can we do that one more time? So look at the height.
Ooh, I heard it pop.
But
Very,
think about what that's also doing at the ankle and the pelvis.
very impressive.
My pelvis and my hips, like this. My belly.
Is there a reason? Did you dance? Were you a dancer? 'Cause
No.
sometimes that will be, when somebody does a lot of dance, they'll end up with this.
Yeah.
That is marvelous. Thank you.
So then what we can help with is maybe getting firing pattern reflexes oriented in such a way. Then ideally her homework is to do some solid isometrics of like stopping here and then doing this
Not letting yourself do that.
to try to teach that endpoint. But it's always going to be there, right?
Yeah.
The hypermobility, or if somebody has really bad osteoarthritis and it's hypomobile, like that's not necessarily changing, and we're having to shift around. But in either one of those categories, where we can certainly be helpful, and at least helping things get worse slower, is by thinking with these firing pattern elements. So on some level, it's always going to be a case where here and here are where I've done the interventions with this the most. It's never going to be bad for somebody to have a strong vastus medialis and a strong gluteus maximus. That will always be helpful because those muscles, this will help protect at least the patella. If not with extra tone, maybe limit the tendency to go too far. Gluteus maximus does a similar thing at the pelvis. And there's a thing there where when the glutes kick on, they pull you more into this posterior tilt, which limits the tendency to go into hyperextension at the knee. So the two together are one of the better connection points related to the firing patterns that we're going to show, where everybody will always be happier and healthier as a human if these things are made stronger.
And even if it, and then the other one that will work with this thing is
Gastroc hamstring.
gastroc hamstring, which is in the flexion orientation, what is happening here. So hamstrings have two jobs. From the midline up, they're extensors. From the midline down, they're flexors. So just because somebody can do a straight leg raise doesn't necessarily mean that their hamstrings are fine. They could be short at the knee, or they could be short at the hip.
And the tendency is they're short at the knee
Yes.
and long at the